My name is David Josephson, and I'll be talking about the treatment and surveillance of non-muscle invasive bladder cancer. Non-muscle invasive bladder tumors represent a heterogeneous group of cancers divided essentially into two groups, low and high risk. But recurrence rates and progression rates do vary, but the most important factor for this is the stage. TA tumors, which are confined to the mucosa, account for 70% of non-muscle invasive transitional cell carcinomas, while T1 tumors account for the rest. It should be noted that the natural history of all non-muscle invasive bladder tumors is of either recurrence and progression to higher stage and grade disease. Low-grade TA diseases rarely progress. Only 2% of them will actually go on to progression to higher invasive disease, but they do frequently recur, with 70% of patients with this type of disease needing repeat resections. Factors that influence the recurrence risk are the number of tumors visualized, the time to recurrence. So certainly if you have a recurrence at the first surveillance cystoscopy, you're more likely to have a tumor that's going to tend to recur down the line. Any history of previous recurrence increases the chance of another recurrence down the line, and a tumor size of greater than 3 centimeters. High-grade TA disease accounts for less than 10% of all non-muscle invasive transitional cell carcinoma. It's the high-grade component that has significant impact on progression and poses considerable risk, even with the use of intravesical therapy. And I think anyone with high-grade TA disease should have a repeat TUR to assure that there's been accurate staging. Intravesical treatment, typically with either BCG or mitomycin, will have 50% of these tumors recur and 25% of these progress. These lesions should be regarded as malignant and demand vigorous treatment and follow-up, because they're potentially lethal, and 20% of patients with high-grade TA disease may actually die from their disease. T1 disease has high incidence of progression. 35 to 48% of these progress to muscle invasive disease within 3 years when treated with TUR resection alone. And so T1 disease mandates a repeat TUR to assure accurate staging and removal of residual tumor burden, especially if there's any concern for adequate muscle in the initial biopsy. We know that these are frequently understaged or misclassified. The European Organization of Research for Treatment of Cancer, looking at 1,400 patients, has noticed that 10% of patients are upstaged to T2 disease on just initial review of pathology. And when there's a lack of muscle in the initial specimen, 50% have residual disease or are true muscle invasive disease. Nevertheless, the depth of invasion in the TURBT specimen is an independent prognostic factor for patients with T1 bladder cancer. T1A, invasion superficial to the level of the muscularis mucosae. T1B, invasion into the muscularis mucosae. T1C, invasion through muscularis mucosae but superficial to the muscularis propria. There's worse prognosis with increasing invasion, and up to 90% of cases can be substaged according to the depth of laminar propria involvement, with collaboration between urologists and pathologists. When concomitant with T1 disease, carcinoma in situ can increase recurrence rates from 43% to 73%. Half of these progress to muscle invasive disease down the line, and 20% will ultimately die of metastatic disease even with the use of intravesical BCG. Carcinoma in situ requires lifetime surveillance, especially of the upper tracts and prostatic urethra, because it's a highly recurrent and progressive disease. These are some of the important factors for recurrence and progression. Nearly 60 to 90% with non-muscle invasive disease will recur if treated by resection alone. And factors that influence this are grade, the depth of invasion, the number of tumors, tumor size, the concomitant presence of lymphovascular invasion, having a recurrence at the first 3-month surveillance cystoscopy, and concomitant presence of carcinoma in situ. Based on previously established data, a risk group classification system combining the aforementioned prognostic factors has been suggested. In a multivariate analysis of almost 1,500 patients, risk groups were assessed by combining stage and grade, and recurrence, progression, and overall survival were noted to be different among the 3 groups as mentioned in the slide here. The management of non-muscle invasive disease, the video on top shows a cold cup biopsy of a small papillary lesion. Initial TUR or biopsy is preferred because it allows for histopathological assessment and to rule out muscle invasion. The use of laser resection has no impact on recurrence rates, but the lack of tissue for staging or grading does make it a problem with regards to assessing for potential for recurrence or progression down the line. This video on the bottom is actually a video of a resection of a papillary lesion using electrocautery loop through an endoscopic approach through the urethra. Cautery is applied to the lesion to resect the specimen and to allow for accurate histopathological assessment with deep biopsies obtained of the muscle to rule out T2 disease. In terms of the role of re-resection for T1 transitional cell carcinoma, I did mention this previously. There is persistent tumor noted in almost 30% of patients who have TA disease and up to 40% of patients with T1 disease. Even if the cystoscopic appearance is normal, a significant proportion of patients will have residual cancer in the resection bed. Only 20% of high-grade TA disease is considered to be true high-grade TA upon review of the initial pathology, and up to 30% of T1 tumors are upstaged if there is no muscle in the initial TUR specimen. So, adequate staging and histopathological analysis is critical to further recommendations regarding any surveillance or intravesical therapy, or even more aggressive therapies such as early cystectomy. In terms of intravesical therapy, this is clearly not used in all patients, and the traditional indications are for patients with multiple or large tumors, certainly greater than 3 centimeters in size, patients who've had early recurrence, those with high-grade TA disease, any patient with T1 disease, the presence of lymphovascular invasion or concomitant carcinoma in situ, or when there is positive cytology after resection of all visible tumor. The available agents in the chemotherapy arm, either mitomycin, thiotepa, doxorubicin, epirubicin, gemcitabine, and valrubicin. In the immunotherapy arm, BCG is the most commonly used agent, and additional agents such as interferon, vitamins A, C, E, and selenium, and propyramine have been studied in the past. Perioperative installation of chemotherapy